Good morning. Good morning, Oley 2025. I'm very excited about this session. I'm excited to build on what Trinity talked about and the collaboration and transitioning. Whether you are a patient, a clinician, or industry professional, this session is for you. I'm sure many of you can attest to, the transitions of care, which, we use that term, but what we're referring to is the movement up from care settings. So going from the hospital to home, home to the hospital, for home nutrition support patients can be really complex. And I'm sure you all have seen the good, the bad, and the confusing. So I'm very excited for this session. We have a panel of experts, clinicians, and those with lived experience. And we're going to talk about a framework that we're developing, the primed and ready to grow. So what does that mean? So this framework, we want to identify the gaps. So where do things fall through the cracks? Some common causes of miscommunication and lack of continuity. Then we'll talk about readiness and resilience. So how do you assess if you're ready for discharge? Can you manage your health needs at home? Are you able to do everyday activities? Do you have the support you need? And then ownership and oversight. We talk a lot about Oley whose job is what? How do we decide who's responsible for what responsibilities? And then we'll talk about workable solutions. So some practical interventions that have improved transitions in real life. And so I'm excited to introduce our first panel, or I'm calling this a morning show vibe. So the Oley morning show, we're just having some casual conversations and trying to impart some real life collaborative solutions for this really complex process. So I'm very excited to introduce Dr. Mercer, and he's going to talk a little bit about gaps that he sees in the healthcare setting.
Well, good morning again. I'm going to stand up and wander a bit. So I'm going to pivot ever so slightly for the first couple of minutes of my talk because I really want to build off of the stuff that I took from the speakers this morning. And so I think they really gave us excellent examples of transitions, right? There was lots of, we talked about sort of the transition, how when there was the shooting in the church, that was an opportunity for a race riot that was transitioned into something that was completely different. And we heard Trinity talking about all of these different sort of critical things that happened to her that could have derailed everything and sent it in a different direction. Every one of those things being a transition, and she approached those transitions in a way that made them positive experiences. And so it really struck me because what she was saying, and I talked to her about this, is it was very aligned with how I feel like we as a field should go. I think that from the medical side of things, we have tended to say, this is what must be done, and you have to live within the constraints of what must be done. And I think that we're wrong about that. I think I was wrong in my own career, and I'm hopefully correcting that, and it's largely in part because of stuff that Marie Newman has taught me, is that we need to change the way we think about it, and the quality of your life should be the thing that drives all of the different decisions. And so we don't need to worry necessarily so much. Remember how she said she used to follow volumes all the time, and she was watching what was going on, and then she realized, all I really need to do is think about how I feel. And then I can go off of how I feel, and all those other things are just surrogates for how you feel. And so I really think that that's an important thing. And I just want to touch on sort of one other thing that she said that I just think was so important, which is, so in Buddhism, we talk about the idea of suffering as being distinct from pain, right? So pain is a thing. Pain is, in a way, pain is like vision. It's a feeling. It's a specific thing that you have. But your suffering is how you approach that pain. So if you're resistant to that pain, then that causes you to suffer. And so when you look in her case, she had all kinds of things that could have made it go sideways, but she didn't resist them. She didn't say, well, this is great, I can't compete because now I have this problem. She just rolled with it. And so suddenly, even though you still have pain, you still have the symptoms, you don't suffer so much. And I just think that's a really, really important thing to bear in mind. And it's something that I've tried to share with our patients. Okay, so I'm going to talk a little bit about just what are the actual gaps, and I promise you I will not talk for very long. I'm going to just lay this out for you because I think some of the stuff I thought I might touch on is actually going to be better dealt with by the subsequent speakers. But so what are the transition gaps? Well, what's the first big one? I would say getting brought into the medical system, specifically if you're having an acute admission to the hospital, right? So transitions are not always home to hospital, coming from or from hospital to home, but rather coming into the hospital is the first big scary transition. Why? Because in your home, you have control of your environment, you're used to doing things a certain way, you have your own protocols, you know what cleaners work on your skin, what dressings don't cause you to itch, you know, how you're going to do everything, and then you come in to a hospital where somebody probably, you know, has really never worked with the central line anymore. You know, they don't know what a Broviac is necessarily. They don't know how to use a G-tube. They have their own way of doing things. They have their own ego. They have their own protocols and everything else. And this is a very vulnerable time for you as a patient because you come in knowing what you should probably do to look after a lot of your own care. And a lot of that can be devalued. People can sort of say, look, you know, just trust us. We're the healthcare providers, and you just worry about yourself and just be the patient. And to some extent, because you're in the hospital, you are accepting some of that. You're sort of saying, okay, something has happened that doesn't allow me to be in my own environment, so I need your help. But at the same time, I really kind of know what I'm doing with 90% of everything that's going on. So that is a first real vulnerable gap. And the best that I can say, from the medical side of things is to the extent that it's possible, come in prepared. And this is something you want to do when you're well. And this will probably get touched on by the others, so I won't do too much. But the more information you can bring along with you when you come in, the more we can minimize that problems in that gap of transition from the home kind of well you to the in the hospital not so well you. So that's going to be one of the places where we can have a critical gap and where your TPM prescription can get changed, where you know, they might not have meds on formulary, where they don't, you know, your line is broken and they don't have a repair kit, or they don't have the G-tube that you normally use, and so instead of having a Mickey, you end up with a dangler because your G-tube pill out, and they just don't have Mickeys or something like that. So that's going to be one area that's a problem. So then you have your hospital stay, and we know there's good and bad about that depending on what it is. The next transition that can be a real problem for you and can provide a big gap is that transition back home again. Now, interestingly enough, in my own experience, and patients may have a different perspective, but that sometimes is the smoother transition, not always, but hospitals seem to invest a lot of infrastructure and money in getting you out of the hospital, right? But there's nobody who meets you and goes, hey, welcome to the hospital. How can we make your transition into the hospital go really, really good? But when it's time, when they get the sense that you're going out, all of a sudden there's, hey, there's a patient care coordinator around every corner who's trying to set things up for you. And what can we do to get your butt out of here quicker? Well, I don't think everything is quite in place. Don't worry about it. We'll take care of it all. Everything's going to be okay. So the system is designed a little ass backwards to help everyone in this room. But hopefully the fact that they've committed those resources to trying to turn over the beds maybe is of benefit to you, in that at least there's somebody who will maybe make some phone calls and try to make sure things are okay. And I think bigger places and more sophisticated systems will be having home care coming into the hospital and making sure that your transition is as smooth as possible. But again, that is a time of challenge where there can be a gap in care. And I'll reserve my comments to the question and answers. And a final transition, or a final place where there can be a gap, is when you're actually transitioning provider to provider. So this is like completely outpatient. One notable example is the peds to adults transition, right? It's very, very topical in pediatrics right now. So pediatricians do a really good job of it. The problem is the other end of things is the end that is not so good, which is the adult side. So you can find good adult providers, and there are wonderful people all around the country. But they're hard to find, and the pediatric people don't know. And pediatrics is a very touchy-feely world. I do both, and so from our program specifically, it's really easy because just peds is on Wednesday and adults is on Tuesday, and so transition is just a day of the week, so it's kind of irrelevant. But that's a tough transition, that peds to adult transition. But I think there is a whole literature behind how to do it properly, and so that we are really working on trying to make that better. And if you can find an appropriate provider, on the receiving end of things, I think you can minimize the harm from that transition. And then finally, just the transition between, say, adult to adult care providers. That can be another possibility, another potential gap. But not every transition is a negative transition, right? Some transitions can be positive transitions. So it can be that you find a program or you find a provider who's engaged in your care, and despite the fact that it's a transition, it doesn't have a negative implication, it's a positive. And so I think those are the areas where we have vulnerabilities and where we have to do what we can to try to make people's lives as good as possible and make sure that we don't drop major things off. And the only thunder I'll steal from everyone else is if you're fortunate enough to have a program that has the infrastructure to support this, they can do a lot of it for you. But for the majority of you, you're gonna have to be your own advocate. And that's a hard thing because it's already hard enough to just be the patient. It's already hard enough to do all of the care for yourself that you have to do. But this healthcare system is not necessarily designed to protect you. And so you just, at this point in time, we have to just kind of buck up and protect ourselves. And this may be a place where Oley has a real important role as an advocacy and professional organization. So I'll leave my comments with that, and I'll hand over to Vanessa, and you can take over the next bit.
Thank you. I'm a pharmacist, and so my topic is to talk about some of the medication management issues with the transitions of care. So, and it's hard for me to read my own slides, but I think I know kind of what's on there. So I want to talk about what are the gaps. Thank you. What are the gaps in the medication management process? The transitioning in and out of the hospital. And then what can we do as a patient or caregiver and as clinicians to aid in this transition. So first I'm going to talk about the transition from hospital to home and what are the gaps. So one of the gaps that I see, again, as a pharmacist is patients are on these medications as an inpatient that they may not be going home with. And especially like there may be IV medications that are switched to oral route, and maybe that oral route's not tolerated or it's not absorbed. But are we really giving adequate time to assess that? Are patients medically stable before they're discharged home? Again, we're trying to push these patients out the door, and are they ready? So that's one gap that I do see quite often. The other gap is if the home enteral or parenteral nutrition is a new therapy, our education is just lacking in most institutions. That's just a fact, and that's what we have to deal with. So to be aware that that is a gap that exists. You're not alone. It's everywhere. And then the last gap that I have listed there is this lack of transparency in the order itself, in the nutrition support order. It's a medication. It's considered a medication, but it's way more complex than, your average medication. So these electronic medical records really are not built to accommodate the complexity of these orders. And so what happens is, it's just unclear when you go into different settings, what is the HPN or the HEN order? Where is it? How can I find it? So that's a gap. So some tips. I want to talk about some tips. And the first focus is on the clinician. What are things that the clinician can do if you're a clinician in the audience? First is, let's make sure that patient is stable before they're discharged. If they're on medications that are not continued in the outpatient setting, we first want to assess that to make sure. Oops. Did I do that?
No.
What's going on? Okay. Let's see what else here. What are my other tips? And, okay, medication reconciliation is a process that institutions are required to do, and what that is like a cross-check between those inpatient orders and then the discharge orders. So there needs to be a thorough process with the process of discharge to make sure that those medications that need to be continued on the outpatient side are all in place. And then the education. We need to do better at ensuring adequate education and then documentation of those discharge medications. If it's in the electronic medical record that you as a patient have access to, or if it's in a written format, all of that needs to be documented so that patients know what they're going out with. So let's talk about what you as a clinician, you as a patient or family member can do to aid in this process. Ask questions. If you're on a medication, starting a medication, you should know all of those medications that you're getting on the inpatient side and the reason why you're getting that medication. So then you know, is it something you're going to need to continue on the outpatient side? When you're discharged and given this discharge medication list, you want to know why you're on all of these medications, what the indication for use is, making sure you adequately know how to administer that medication. Is there any self-monitoring that's required? How long do you need to stay on this therapy? If you need refills, who's responsible for the refills? Who to contact if you have questions? These are all things you want to know before you're discharged, because guess what? Once you go home and you have these questions, it's not always easy to find out who do you call, who's responsible. It's much easier to get those answers before you're discharged. So home to hospital. When you're readmitted, what are some of the things, where are some of the gaps? Are all of those medications that you should be on, were they continued on the inpatient side? Not always. There's some gaps with that. There are issues with hospital formularies where they may not carry that medication. Maybe it's a hospital policy. For example, maybe they don't do heparin flush, but you are using that in the home setting. Are there product shortages where they're substituting a medication that you were stable on? So those are all potential gaps. And then, does your hospital have a policy that allows for use of especially the parenteral nutrition side? They may not allow you to bring in your bags from home. I know at Vanderbilt we do not allow people to bring their bags from home. So you want to know that ahead of time, or at least when you get there to ask that question. But if they are allowed, is it being given appropriately? We know that that's been a problem too. So some of the tips that we as collaboratively can do, clinicians and patient caregiver, is really, first of all, that medication reconciliation process needs to be thorough with the inpatient process as well, coming into the hospital. Did we miss anything? So when you're in the hospital, you want to know, is there something that's being omitted? And then to ask about that. Really to kind of know ahead of time if you're allowed to use your bags from home. So my final slide is really looking at this transparency of the order that I talked about, or lack of transparency. And this really has to do with this electronic medical record. And I think we as a healthcare professional need to do a better job of really promoting this process of making sure there is transparency. So when patients come in and out of the hospital, that the complete order is available for providers to see, that nutrition support order. So recognizing that there is a gap, as a patient and caregiver, I think when you are being admitted at a hospital, take a picture of your label. Be prepared to provide that information to your clinicians, and or at least the phone number of who to contact, your home infusion provider to contact to obtain that information. It's very important to have accurate information with that. And as a clinician, we need to do due diligence to make sure we obtain that information. And the same when you're discharged from the hospital, I would say, I don't think we do a real good job of contacting the home infusion provider to give them the heads up. And I think as a patient and caregiver, you need to, be in communication with that planned discharge, especially if it's a Friday and you may be going home over the weekend, and that home infusion pharmacy is not going to be able to mix bags over the weekend. Do you have bags already in date at home? Those kind of things. Be proactive and prepared for that. And as clinicians, we need to do a better job of providing that continuity, contacting the home infusion pharmacy, making sure that the order is relayed to the provider. So with that, I will go back to Andrea.
Yes. Well, thank you both for sharing, some of your insights as far as transitions and the gaps in the hospital and also with medications. And we know that these gaps can result in complications for patients in real life, right? So if we were going to dream a little and you had a magic wand, what changes or redesign a step of the transition process, what would you envision? What do you think could make it easier?
Well, some of the things that we've actually done, I think what you want as much as possible is one team that you trust that's with you all the time. And so what you really want is, ideally you would like, for example, the same dietitian that manages you outpatient, manages you inpatient, and the same home care provider has a very tight relationship with that person, so that those transitions, the actual TPN prescription transitions, go very smoothly. And I think you have to have, ideally what you want is a team that's engaged enough and resourced enough to be able to alleviate that burden from you, to make sure that, so while, ultimately you want to stand up for yourself, you also have enough stuff to do, and you don't necessarily want your whole life to be figuring out how to not die during a transition. So I think ideally you would really, in a perfect world, it would be a system thing. Nationally, that won't happen, but you can make that happen locally. So there are ways to build little mini systems in your own life with people that you trust, and there are ways, we talk always about building up your team of trust, and there are ways to do that. So.
Yeah, and I think that's an important part because, so many of our members aren't at a center of excellence or have a team, and so it's figuring out who that team is that you can build. So maybe it's your home infusion dietitian, maybe it's your primary care, somebody that's signing off on your orders and figuring out how can you get them behind you, and build your team that way, even if it's not this quote-unquote team at a center of excellence. So great, thank you.
Yeah, and I just want to add to that. It's even when you have this team, we do have patients, that live at a distance, and it's a challenge when they're sick, they don't want to travel all the way back to their, primary team or institution. So when they're admitted locally, I think it's sometimes hard because then when things go wrong, I had a patient just on the other day that wanted to be transferred in, and we're at capacity, they denied the transfer. So those are all really, sad complications that can happen, but, coming into the emergency room at least would have been a way to help expedite that. But I understand it's not always feasible to do that, but ideally when there's, a complication going on, coming back to your team is always preferred.
Absolutely. And I would say my last question for you two is, in your experience, are there any simple steps or mindset shifts that maybe could have prevented a breakdown, a gap in care?
So that's a tough one to answer because there's so many systematic problems that I think that the simple thing, I won't even address the medical side of it because there's like a million things to change. So, but maybe the one intervention is this whole idea coming back to of the sort of ultimately you being responsible for it, and that's amassing your little packet, which is actually really important to us. I think that's when you show up with the 2-page brief history that's got your surgeries and your procedures on it, and your med list, and a picture of your prescription. And if you have unique things that people don't believe, right? If when you say I can't eat, and they go, well, how can you not eat? Of course you can eat. I mean, you don't need to be on TPN. Just, gee, this specialized team doesn't know anything. If they just fed you, you'd be fine, right? If you can, to the extent that you can, build up a little bit of documentation that you have with you, I think that is one way. At least there's one thing that is consistent, and that can be something you can turn back to. And you can hand it off to somebody and go, here's my stuff. Now, if they choose to not look at it or not ignore that, you've done the best you can. That's on them at that point, right? And then it's a system problem, and we get into the other side of the equation. But for the things you can control, that's what it is. Control what you can control.
And I would just add, I think the communication is very important, and to be concise. And I know sometimes it's hard, you know, as a patient or caregiver, sometimes I think the tendency is to go kind of down a rabbit hole and to talk about sometimes even things that happened in the past. But I feel like knowing your history in a concise way and to be able to articulate that, and even if it's not you as a patient, but having a family member or someone else there to speak for you, especially if it's in a situation where you're not really capable of doing that, I think is going to be very valuable. And the other one little piece I forgot to mention before that is one of my pet peeves that I think patients really need to do a better job of is keeping their medication list updated. So every time you go into the clinic and you see your medication list and they're like, yeah, whatever, it's okay. But just to be very detail oriented and going through that and updating that, because if that record is updated, it does make it easier with the transitions going in and out of the hospital. And that medication list oftentimes does carry even to other institutions through the electronic medical record. So that's something you can do as a patient or caregiver. I think that will really be valuable.
So I'm hearing like a bulleted list, right? No paragraphs, just bulleted list, updated medications. Perfect. All right, well, thank you both. And now that I'm going to invite Tanya Henry and Lucas Borges up here to talk about, now that we've explored kind of where things can fall apart, how we can prepare better from the start. Thank you.
Hello, everybody. I am Tanya Henry. I'm from Texas. I'm a military vet, and I just wanted to give you a little bit of history, my backstory. All right. My medical journey with TPN and everything began actually when I was in the military. I was undiagnosed. I was told, you just have a virus, you have IBS, you know, it'll pass, here's some Zofran, let's give you some fluids, and that was in the mid-90s. Well, then after that, long story, it went all the way from there to started around 1995 to 2014 is when I got my, my emptying study. So I went all those years not even knowing that I had gastroparesis. So after that, that was at the VA. From that point, I had the test. The doctor gave me Reglan, and the VA said, this is all we have for you. So 2015, my weight drastically reduced. So I asked them, you have to send me somewhere else. And I demanded to go to MD Anderson to see the motility specialist there. So I was there, and we did diet changes for a little bit. After the diet change was not working, so my doctor said, let's do the gastric stimulator. That was in 2015. Then that only worked for about 1.5 years for me. So in 2017, I got a J-tube, which is a jejunostomy a tube in the small intestine. Then went on tube feeds or enteral nutrition. So that was still 2017. From there, still having issues. So along with MD Anderson, I started going to a tube clinic, which was in Temple, Texas. So one is a little bit north in Texas, and the other one from that point was 4 hours south. And I lived in the middle of both. Then we went from a J tube from the small intestine to a GJ, and that is, a gastrojejunostomy. So then after that, still stayed on tube nutrition until 2019 when I'm still having issues. So that's when we went to TPN. And I also at that point went from a GJ to only a G to vent. And ever since 2019, I've been on TPN and still have a G tube.
So my name is Lucas, and before, just wanted to say how blessed and lucky are we to be here as a community, and thank you to everyone for being here and the whole team for putting this together. And I hope if there's anything you take from today and this week, it's that it's not just about being alive, but really living, right? And never losing hope throughout any of this. And I think we've heard some amazing stories, and Trinity's story, and about what's possible, with TPN. And my story, I should preface with, I was afraid of needles. So I was 22 years old. I had just graduated from Harvard. I was working on Wall Street and was skiing with friends when had lifelong skier and hit a pole doing about 60 miles an hour in a crazy freak accident. It was enough force that my L2 vertebra hit the pole and severed the superior mesenteric artery in between. And so I was rushed to the hospital, CPR in the ambulance twice. And my heart stopped for 10 minutes, about 30 seconds after I get to the trauma bay. And the doctors went above and beyond. I went through 177 units of blood, lactate above 16, pH below 6.9. I was bleeding out. And really, should not have survived. But they went the extra mile, and that's frankly why I'm still here today. So to clinicians and everyone else in the room, the work that you do really does matter. At the same time, my bowel died from the lack of blood flow, so I have 6 centimeters of duodenum connected straight to transverse colon. So I've been on TPN for 4.5 years, and I get it 12 hours a day, every day. And one of the, when we talk about transitions, Dr. Mercer was one of the first doctors I saw after, and he told me, you got to get used to the new normal. And that was frankly one of the hardest things I've ever heard. And at the time, couldn't have imagined looking back on it, but he was totally right. And if there's anything that I would tell myself at the time, it's that, don't focus on what has to change, because certainly a lot of things will change. But don't let that distract from what doesn't have to change. And there's really no substitute for time. So maybe as we talk about transitions.
All right, I just wanted to discuss a few of the transitions that I've personally had. That was going from, solids to liquids, from liquids to tube nutrition, EN, from EN to TPN or HPN, and also from home to hospital, hospital to rehab, rehab back home, changing different infusion companies. And another transition is also going from having a port to a PIC to a Hickman, and the ones that I like and don't like. I personally, I hated my PIC line. That was, to me, the worst transition I could ever have. And I am a a patient who likes to take care of themselves. So when I had my port, and I had 2 separate ports, I always changed my own port needle. That's something that I love to do. I do have a home nurse, but she didn't really do much for me except draw labs. One thing that they said they required was to have her change my port needle out. And so she came and I said, okay, are you going to change my port? And she's like, oh, no, you go ahead and do it. You know how to do it. I don't need to do that. So I feel that if you can do it and you're comfortable with it, if they're willing to train you and allow you to do that, that is something that I suggest and that I prefer. But as far as going from oral nutrition to EN, I was given my jejunostomy as an outpatient. And so I got my J-tube, I went home the same day, and they said, okay, there you go. But I had no nutrition at all, nothing to go with the J-tube, and my surgery was done 2.5 hours away. I go home and I not immediately, but I would say 3 days later, I had a complication. I woke up to a blood-soaked shirt, cover, bed, everything, and I drove myself to the hospital. The nurse was like, no, I think you need to call 911. I said, no, I got it. I'm just going to drive. So I drove to the hospital, and I had to get clotting factor. So to me, something that I feel like it should happen when you get any type of tube, a line, or anything is you need to be given the instructions. You need to be given supplies. And if they can't get that to you, you need to be kept inpatient until you can get it. So I did not get my nutrition for 2 weeks. So I was still stuck without anything, even though I had a J-tube. Didn't get set up with home health for 2 weeks. Then I had to go to the VA to get a pump and didn't know how to use it. So that was another one where I had to do my own research to figure out how to use the pump. And then the transition from EN to HPN was a lot smoother because I had a specialized GI team in San Antonio, and my doctor ordered it. I had the pre-labs that were done in my home, and then my nurse came to the house, set it up. She watched me for about 2 hours and said, you're good. She taught me how to set it up. I took my notes. I like to write things down, and I like to have notes for everything. And I posted those notes on my bathroom mirror. That way, my daughter can help me if I ever need the help. And I've taught her how to set my TPN up and everything, so she does that for me when I cannot do it. The transition from home to hospital, whenever I've gone, has not gone that well, and I hate being inpatient. So I would say, like, when you're in the hospital, it does not always go as smooth as you would like. And I am that patient who you bring the medicine in. I'm asking, what is that you're getting ready to hang? And there are times when I will say, nope, I'm sorry, I'm not taking that. And they're like, what? I'm like, nope, I'm not taking that. The doctor did not tell me I was taking that, so I'm not going to do it. Doctor comes in, I hear that you don't want that medication. Why not? I said, well, I don't think I need it. And I actually had bacteremia a few years ago, and the doctor said, we're going to do 2 IV antibiotics. Then the nurse comes in, 3 IV antibiotics. So I'm like, nope, not doing that. He said 2, I'm doing 2, not 3. He said, well, you have primary immunodeficiency, and I think you're going to need a 3rd. And I said, well, I don't think I need a 3rd, so let's just try the 2. So we did the 2, and then that was it. But I mean, it went on and on and on, but I don't think that was my fault. But so I can be that patient who is a little, I don't say stubborn, but I just feel like if I don't need it, I'm not doing it. And I do have a little bit of a medical background as well, so if I don't think I need something, I'm not taking it. I can say the transition from the hospital, the home, to rehab, something that I did like is my infusion company has a VA liaison. So anytime I transition from whether it's home to hospital, hospital to rehab, rehab back home, or even when I went from one branch of my company, infusion company in Austin, to now a branch that's in Minnesota, the VA liaison was there to make that transition as smooth as possible. Anytime I have an issue, I can call her or text her, and she will contact the VA on my behalf. They will work together. The only thing I don't like is sometimes they don't communicate with me. They communicate between each other and not myself. And so we ran into an issue where they decided they were switching my company to a different one, and I said, no, I'm staying with this company. So she had to contact the VA and said, no, the patient wants to stay. And so I said, it would have been helpful if someone would have contacted me in the beginning and we wouldn't have had to go through this, because I got a call from the other company saying, hey, we need your information so we can send you your supplies. I said, who are you? She said, I'm your new company. I said, no, you're not. I'm with this company. So then once I talked to them and got them to talk to me, we worked it out. So I stayed with that company, and I've been with the same infusion company my whole journey. And I don't like change, so I like sticking with that company. When we have problems, we work the problems out. And I feel like that's something when you're going through a transition that you have to do, is you have to be able to communicate. And if you are new to TPN, I feel like you should get used to your company, get to know your company, get your contact information, and that'll help make your transition smoother.
So I was asked earlier, we all hear about what does it mean, patients should advocate for themselves, and it's all about communication between patient and their clinicians, and, but what exactly does that mean beyond, advocating for yourself? And in my experience, to patients, I would say two things. One is that don't complain, but explain, right? And I think you get taken a hell of a lot more seriously when you can be objective, about what's going on, what you need, what your positions are. And at the same time, I think secondly, maybe Bill Russell, the legendary Celtics player and coach at the same time, is a good example, or Tom Brady, maybe, to the Boston fans out there. You really are, both the coach and the player at the same time. No one else has the 360 view of everything going on the same way you do. And at the same time, you wouldn't ask, an NFL lineman to go run a 40-yard dash and catch a pass and, score a touchdown. Same thing in the hospital, right? And same thing with everyone involved in your care. Everyone has a role, and it's your job as a patient, really, to map out how everyone fits together. And I remember, some of the first hospital interactions with my mom. Someone would come in to clean the room, and she'd bombard them with a list of questions, and you can see them glossy-eyed, like, whoa, I have no idea what's going on. But it's true, and even if you're going to IR to get a central line placed, they're not used to placing central lines for TPN, and so you might tell them, hey, instead of putting the cuff right at the edge where it's easier to pull out, I'm going to stick with this for a long time, so put it higher up, and not just a little bit higher, but up by my collarbone, or whatever the example might be. But I think that's an example of, if you give people context, and you give people context of how that fits into the broader care plan and your broader experience, that tends to work really well. At the same time, for clinicians, one of the phrases that stuck with me was, remember what it was like to not know. And I was 22 when this all happened, when I started on TPN, 23 when I got home. And I couldn't have imagined, the perspective and how time would change things. And there really is no substitute for time. As a patient, your perspective really does change. And I think maintaining hope throughout all of it is sometimes just gets tomorrow. And know that it gets better. But to clinicians, this is, you might be seeing someone for, what is their first time, and you might have, a view of what's to come and what's around the corner, and giving them that perspective of, this is trying to remember what they know now and what they will know, and just keeping that in mind when giving them, advice, perspective. And the other thing is just going the extra mile really does make a difference. I think it's the easiest thing sometimes to stick to a normal course of action, but when you engage with the patients and when it goes well, you have those goals. You saw from plenty of stories today, and you'll continue to hear about some really incredible things that people do on TPN, on any kind of nutrition support, and that really shouldn't limit you. And it really is coordinating with everyone involved to come up with a safe plan. But to clinicians, when you go the extra mile, it might not be easy, it might not be convenient, but it really makes a hell of a difference for quality of life. And I think that's really the whole point, isn't it?
Thank you both. Well, and it sounds like if I were to summarize, Tanya, it sounds like what has helped you kind of be ready with your transitions is you've taken a very active role in ownership of managing your line and your therapies. And I think sounds like that probably helps you be ready when you're doing these transitions and be more prepared. And I heard lots of communication, right? Communication is key. And with Lucas, it sounds like perspective, right? And looking at things differently. Your journeys have both been different, but you have these perspectives and experiences. And we don't have much time, but if you had something that you were going to tell somebody who's earlier on in their journey, something that you had wished you had heard, or if there's something that someone had said to you that really was able to kind of shift your mindset, even if you weren't feeling quite ready for that transition, if you would share.
I would just say, whatever the doctor tells you, when he tells you a condition that you have, or you're going to have to get a port, or they say they want to place a line or a tube, it's very important to know exactly what types of tubes there are. Are you getting a nasal? Is it going to be a surgical tube? What kind of line am I going to get? Ask those questions. Where is it going to be? Do I have a choice in the type of line or the type of tube or anything? So I feel like asking questions, doing your research, and finding support groups, those are the things that I would suggest for anyone who's new or anyone who is already in that journey but you don't have a connection. There are lots of groups out there that you can find to connect to.
Thank you.
And I think I would just add that don't let your own mental blocks limit you. I don't think there's, when I first had the accident, I think there was a lot of, oh, my life is totally different. A lot of focus on, I can't do this, I can't do that. But at the same time, it's, when you stick with it and you're like, well, I think that's a really good point. Don't stop asking questions. Well, I want to travel. Well, I can still travel. I have to pack a couple things more, but you can still travel. I want to play sports. Well, I got to be careful with the line, but I still play soccer. I still ski. And to anyone, I'd say, don't let your own mental blocks, limit you. Keep asking questions, and if there's something you want to do, more often than not, I think you can figure out a way to go do it. With working with your team, working with your family, working with everyone involved. But there's a way to go do anything you want to go do.
Thank you. Thank you. Well, and now that we've talked about readiness and how to be ready, we're going to talk about ownership. So who is owning what? And so now I'll invite Marie and Kaylee up to the stage. Thank you.
Hello, everybody. Oh, is this on? Okay. Hi, everyone. It's really, really bright up here. My name is Marie. It's so nice to be here. I'm going to just really briefly share my perspectives on transitions from my experience as the mom to a little kiddo. He's the little guy making the funny face at the front, who's on nutrition support. He's got intestinal failure. He's been on TPN his entire life. And I'll also kind of share that my perspectives on all of this are also informed by my research on quality of life of patients with intestinal failure and their families. And of course, in the most traditional sense, right, we can think of transitions as transitions between care settings, so between care providers or between hospital and home. But I think in the context of caring for a child, really everything is a transition, right? They're always transitioning. They're getting older. They're transitioning from one classroom to the next as they age into the next grade. They're transitioning into a new hobby or a new activity. And so there's really never a time where we're not transitioning. And I'm gonna also, as Lucas did, I'm pulling in now a metaphor. I don't have a football metaphor. I think Boston Celtics are football, if I'm correct. I'm European. I don't know anything about American sports, but I'm gonna pull in a gardening metaphor. This is you're learning a lot about me. So I think caring for a child on nutrition support is kind of like caring for a very complex and rare garden. This is my AI picture of a rare garden. But I sort of imagine this, right? Like you're inheriting this garden. You didn't know that you were going to get responsibility for this garden. And it has all of these beautiful rare flowers that most people don't really know how to care for. They've never even seen these flowers before. And the weather in this garden can change at an instant, right? So it might be sunny, and the next second there's a storm tearing through and uprooting your plants that you spent many, many months caring for. And also, there's no manual, there's no instructions. You inherit this garden, and it's go time. And the tools that you need to care for this garden, you have to find yourself. Sometimes you even have to invent them. And I think that's sort of the world that we as caregivers to children with intestinal failure or children on nutrition and support are living in, right? And it's hard and it's beautiful. And every day as this garden grows and flourishes, you have to show up, you have to learn how to tend to this garden with immense commitment and love, and also increasing skill over time. So caring for this garden really takes a degree of dedication and hands-on work that you didn't even know you were capable of when you started this journey. And ultimately, the responsibility, right, is on you alone. And similarly, caregivers of children with medical complexity are carrying so many responsibilities and roles all at the same time. And if we drop the ball, ultimately, our child pays the price. So for example, parents are often managing all aspects of their child's care, and they act as primary care coordinators. They manage appointments across multiple specialties and are juggling insurance approvals, and they're also on top of every subtle change in their child's condition. And then, of course, they also have to become advocates across all of these different care settings, in school, in the healthcare context, and also to make sure that their child has access to the services they need. And they're also communicators, right, and medical translators, really. So they have to explain their child's condition to their child's teachers or classmates, and also then their child's personality and medical history and needs to rotating doctors. And then, of course, these roles extend beyond sort of the logistical and technical management of their child's care to also the mental and emotional responsibilities. So caregivers become teachers, they prepare their child for independence, even when the systems around them really aren't designed for a smooth transition. And they also become emotional lifelines. So they have to absorb their child's pain and fear and questions while really trying to hold it together at the same time. And so these roles then ultimately demand time and skill and emotional strength that really is on par with a full-time job. And what I think is really important to recognize is that all of these caregiving roles aren't fixed, right? They're going to look different in different families, and they're also constantly shifting, sometimes even hour by hour. So for example, in the context of a hospitalization, a parent might go from being a medical manager to then a fierce advocate for discharge planning, and then going back to being the emotional anchor for their child at the child's bedside. And these roles also aren't always compatible, right? So being a calm and steady presence for your child can also conflict with the emotional intensity of fighting a system day in and day out for access to care and services that your child needs. And I think these transitions, for example, a hospital discharge or the move to adult care, really create pressure points where some of these roles move into the foreground and others get pushed aside. And I think this juggling act between all of these different roles is really part of what makes caregiving so complex and is also really under-recognized and underappreciated by those who aren't in the trenches with us. So ultimately, what I've experienced personally and also what I've found in my research is that caregiving to a child on home parenteral or enteral nutrition comes with enormous challenges, both logistical and emotional, and I don't think I have to cover what all of these challenges are because we all know them so well. But at the same time, it also comes with enormous rewards, right? So you have this opportunity to experience a very deep connection with your child and experience a deep sense of gratitude that your child is here and gets to experience a life that you probably thought was impossible at the beginning of this journey. You also have or may have the experience of using your voice for change, whether that is change in your child's care, or in the services that your child is able to receive, or maybe even on a larger scale, using your voice for advocacy in our field. And you may also be experiencing strength that you never thought you had in you when you first started this journey. And so reflecting back on the different transition points, I think these transition points are important to recognize because I think both the challenges but also the rewards and the opportunities for growth are maybe more visible than they are usually, right? So these transitions really demand even more from caregivers who are already doing everything for their children, but they also reveal where the gaps in the system are and where the system fails us, and where caregivers and patients really rise to the occasion, and clinicians rise to the occasion and adapt and manage to keep going. So I'll hand things over to you.
Hello. Okay, it's on. Hello, I'm Kaylee. I'm the education manager for Oley and a registered dietitian by background. I'm going to transition us to sharing some information about how education and clear resources can help define ownership roles for patients, for caregivers, care partners, and for healthcare providers. It's been a recurring theme in the speakers that we've had thus far about the importance of defining those ownership roles, especially during transitions of care. And if those expectations and those roles aren't clearly communicated and defined, the analogy I like to use is like a game of finger guns, where you're just like pointing at the other person in the room, whether you're waiting for somebody else to take action or you're assuming it's somebody else's role or job or it's being taken care of on the back end. It can result in really significant care delays and complications. This is why proper education is so important, and it should be thorough. Educating on, like Vanessa said, it's a big care gap, because educating on simply the administration of nutrition support, if that's being done, it's important, but making sure that we're thoroughly educating on other care components, that we're touching on the day-to-day cares, that we're mentioning, when and how to escalate care. We're clearly communicating the roles of the healthcare team, who to reach out to and when, who's taking care ownership after that transition of care. Oley has some wonderful resources and more to come in terms of conversational toolkits. We say so often to advocate for yourself and to ask questions, but as a clinician, one of the most common questions I hear from individuals is, I don't even know what questions I should be asking. Or did I miss something? Like, what do you hear most often? And so when you don't even know where to start, how can you play that active role in your healthcare? Having thorough education, that's important, but Oley has also built some resources around suggesting some questions to ask to aid in those conversations that you're having with your care team and your care partners. In terms of education, thorough education can help, like I said, clarify those expectations. So thinking daily care and maintenance of the devices that supply the nutrition support. So not just how to deliver nutrition support through said devices, but how to care for that, how to manage complications, being proactive instead of reactive. It can also help with monitoring symptoms. What should we be looking out for? When should we sound the alarm bell? To who? How do we escalate care? And then to provide individuals, patients, and care partners with the tools to do so. How should we be monitoring that? How should we be communicating that to our healthcare team? Either logs, through the EMR portal. We should also be having these conversations and providing education to really empower informed decision-making, really sharing in that responsibility so that patients can truly play an active role in healthcare, being well-informed, like I said, knowing what questions to ask. It's a joke. I've experienced it first-handedly as a patient. You don't often think of those questions until after the provider leaves the room, or you've had an opportunity to marinate on said information, if you will, or you go home and you're trying to apply the instructions that you received at an appointment or in the hospital. So how we can continue that dialogue with providers when we think of those questions. And really reinforcing the importance of communication regularly and to who. So identifying, who is within your care team and who you should be directing certain questions to. And for caregivers as well, providing education about what their supportive role should be throughout this care process. In terms of healthcare providers, Oley also has been building some wonderful resources, actually in partnership with Aspen, in terms of transitional care checklists to really ensure that we're meeting the thorough educational needs of patients and caregivers during these various transitions of care. For healthcare providers, care ownership via education really helps define what that said provider's role is in that individual's care. So not just the diagnostic and treating of whatever care is being addressed in that visit, but also long-term assigning roles and responsibilities for who's going to be monitoring and following up and coordinating different components of care. So, and that can easily be overlooked when we're not thinking long-term versus the here and the now. Having this type of educational role as a healthcare provider also encourages, again, that clarity and communication. How are they to communicate feedback and concerns? So bidirectional communication is extremely important. Having thorough education and bidirectional communication also ensures that the education and communication we're providing as healthcare providers is culturally sensitive and accessible. So think about how you learn best. I'm a visual learner, so if I don't see a process, if you're just giving me some verbal instructions, it's gonna go in one ear and out the other until I have an opportunity to see or to try. So as a healthcare provider, having them teach back or repeat back or somehow assessing that learning, or even asking those questions up front, how do you learn best? How can I support you to help you understand what's going on? It also helps encourage provider accountability, so making sure that we're doing what we're supposed to in terms of providing that education, in terms of making this a part of the workflow, either utilizing checklists as a clinic, documentation requirements, to reinforce the importance of education throughout the care process. Overall, defining care ownership, like we've been talking about, really helps align expectations among all parties. So like I said, care partners, caregivers, patients, healthcare providers, and it helps reduce redundancy, confusion, potential overlap in roles, or making sure that somebody is actually taking ownership of a role that might have been overlooked. It helps foster more of a team-based approach. It also can help alleviate potential burden being placed on the nutrition support consumer. So making sure that we are really sharing in that decision making and sharing in the different care components to help things go as smoothly as possible. It helps enhance trust when you know that certain roles have been assigned. You know who to reach out to and follow up on versus, just sitting around and nervously waiting for a phone call to confirm that something's been done. It also helps reduce some of those complications like preventable errors when we're coordinating care efforts strategically. So key takeaways. Care ownership can help empower patients and caregivers through education. Oley resources can help better clarify these roles and expectations. And education is really needed to facilitate comprehensive, understandable, and actionable education for all involved in the care process.
Thank you.
Of course.
Thank you. Marie, so you spoke so beautifully about the weight that caregivers carry. For other caregivers in the room, can you talk about something that either has helped you on your journey, something you wish you would have known sooner, or something that someone has said or done along the way that's really made a difference?
Yeah, I think I'll share one kind of bigger thing and then one tiny little trick that I use that maybe is helpful to someone else. So the first thing I would say is that about a year ago, we went on our first international trip on TPN, a 3-week trip to Europe. It's one of the craziest things I've ever done, but it was incredible. And our wonderful new home care company really took ownership of helping us manage that trip. And it was a huge gift because I'm so used to having to do everything and make the calls, figure out all the details. And they said, you know what? Let us make the calls for you. We're going to figure this out for you. And so that was huge. That was huge because as we all know, we're already doing everything. And so that was a huge thing off of my plate and everything worked out beautifully. And then the small little trick that I will share is, hopefully this is helpful to some of you. I have a huge hang up about not wanting to hurt anybody's feelings in the inpatient context. But I'm also so hyper vigilant and so uptight about my son's central line, and we never let anybody touch his line. And of course, when you're inpatient, you have to. And so one of my little tricks is that before a nurse even before she even gets within 2 feet of him, I say, you know what, I am one of those crazy moms. My son needs this line indefinitely. These are my hang-ups about his line, and if you could just please do X, Y, Z. That helps me not be in a situation where they're already doing something that I don't like, and then I have to be like, hold on, don't do that. And then they might feel like I'm hurting their feelings. And so it helps just prevent any kind of weird situation. It makes me look like I'm the crazy person, but I don't mind being the crazy person. And it just helps kind of alleviate a situation that could potentially be awkward.
Thank you. Well, and I'm just thinking, for others who are thinking about traveling and they are feeling overwhelmed even thinking about starting to make the phone calls, maybe even just asking their home infusion company, what do I need to do? What are you able to help, right? Maybe trying to define that ownership if they don't kind of jump in and offer to do that. I love that. Thank you. And then, Kaylee, from your work with patients and families, can you talk about maybe some common surprises that catch people off guard when responsibilities aren't clearly defined?
Sure. I would say when responsibilities aren't clearly defined, especially with the care transition involved, oftentimes that's when all the different logistics of putting into place said care changes or nutrition support plan, particularly if this is new to you or if a change has been made, the logistics of actually implementing that into day-to-day life, especially if it's longer term, that kind of comes flooding in. If care ownership roles also haven't been defined, it can be even more overwhelming in terms of, okay, there are all these things I hadn't initially thought of. I haven't been given resources or tools to support me and in some of these questions that I have. I don't even know who to reach out to. I think something else too, we touched on this new normal, if you will. When you experience a major medical change like nutrition support, we don't even know what that new normal looks like. And so also setting clear expectations through education, for example, when you get a new feeding tube, what's normal in terms of discharge, or what should my peristomal site be looking like for an abdominal place feeding tube? Those aren't things that we just automatically know. So that's why thorough education is so important in terms of, the day-to-day logistics, but you're not gonna know everything leaving the hospital or with the new care change. Surprises, questions, all sorts of things pop up, but knowing who is in your toolkit to help is so important.
Thank you. Thank you. Well, and with timing, we're going to pivot a little bit so that we have time for some Q&A at the end. But we've talked about the gaps, how to be ready, who's owning what, and now I want to talk about how to make things better in real life. So I'm going to have Kaylee stay and then invite Vince up, and so you're welcome to go down, and talk about a resource that Oley is working on to better prepare folks and connect people on their journey.
Sure. So some of you all might be familiar with the concept of patient journey mapping. If you aren't, I'll go into it in just a moment. But what's so amazing about the Oley community is the fact that the members of our community are so diverse. And this is different than other organizations in the sense that what has brought you to this point in your journey or along your journey, it's so variable. Other organizations have created tools and resources to support individuals with certain diagnoses or conditions or who are on certain therapies via a patient journey map, kind of demonstrating some of the major milestones, kind of from start to finish, if you will, at diagnosis, what treatment might look like. It's quite linear for other organizations. Think about receiving a diagnosis of a certain type of cancer and what that trajectory might look like for an individual. Yes, there are variations, but it's a bit more linear. And so Oley has been for years brainstorming about how we can better support and involve the community in a visual manner in terms of where are the overlaps in this nutrition support journey. I'm going to use a really personal analogy. I just did a very bad idea, actually. I did a major hiking trip the week before the Oley conference. I don't know what I was thinking. I did the rim to rim at the Grand Canyon. Anyways, I have a terrible farmer's tan that I've been trying to hide this entire conference thus far. So the patient journey map, I like to use the analogy of planning a trip to a national park, let's say the Grand Canyon, bear with me here. For individuals on nutrition support, some have been having ongoing conversations with their care team. Maybe they've reached out, they have a trip planned to the Grand Canyon. They're training, they're preparing, they're doing what they can ahead of time, asking questions. Other people, it's a bit more spontaneous. Maybe some complication has popped up in their medical journey. Maybe something traumatic happened, and this was a very quick, abrupt lifestyle change or need. Some journeys appear, more involved and rigorous. Maybe there's multiple enteral and parenteral therapies involved. Some therapies are shorter. Journeys through the Grand Canyon are shorter, if you will, in terms of maybe this therapy, enteral or parenteral, is needed to help heal or recover from a surgery or a procedure, or until we can get stronger, maybe leading up to a procedure. And so this patient journey map that we are building as an organization really seeks to highlight some of these common journeys, where the overlap is and where consumers can find resources and supports along the way. So we acknowledge that journeys are highly variable leading up to and on nutrition support, and we aim as an organization to really help find some of those key milestones and where we can garner support and further engage our community. So you might see some cheesy park rangers or, other kind of references there, so bear with me. But we're very excited, and I'll turn it over to Vince to highlight some of the ways that we would like to engage the community.
Thank you, everybody, for being here today, and thank you for having me on stage. I couldn't be more excited to navigate this journey. As Kaylee was saying, everybody on this stage that was on nutrition support, their journey was different. We heard of people being born with it. We heard of traumatic accidents that happened. We heard of people that were in the military and then had to adapt their life. So this is going to be a big deal for everyone, and it's going to help the entire community, and I could not be more excited that we've taken this on and started to work with different partners and different organizations and Oley internally. I think it's going to make a huge difference in the community and really involve everybody. The goal with this is to just reach people sooner in their journey and help them navigate that journey. I, as a community engagement coordinator, talk to people every week, and they're so confused about what to do, how to take care of a tube, got a new line. and that is what we're going to change. That is going to be navigating that journey along the way, as Kaylee said, providing those resources, and I couldn't be more excited. Everybody's care is different, and so is their journey, so we need to figure out that care and those gaps and figure out all of that, and I could not be more excited to work with Oley and all of the people that collaborated on this tool that we're working on, and I think it's going to make a huge difference. When people call and as we heard, going home from the hospital with a tube with no education, that will no longer be after the fact of this patient mapping tool. They will have those resources and that education, and I couldn't be more excited, and I wish that when I was on nutrition support growing up that I had this patient mapping tool, but I think taking away from what I wish I would have had, I can put into this patient mapping tool with Kaylee and I and really build this and say, okay, when I was this age, I wish I would have had this. When I was a teenager, I wish I would have had this. When I was in college, I wish I would have had this. And now at 33, what do I wish the journey could help me, right? Because every age we can help. I don't think there's an age that we can't help. I think if you're 5, if you're 65, or you're 85, or you're 35, we're going to be able to help. This tool is going to help you throughout your journey. I couldn't be more excited.
Thank you. Well, what a gift this session has been. We've heard from amazing speakers. Thank you. Thank you all for being here. And the truth is, transitions will always have bumps in the road, but when we're connected and informed, those bumps don't have to send us off the rails. So I hope you can walk away from this session feeling a little more empowered, some tools in your toolbox. And we do have a couple minutes. If anyone wants to ask any questions, we can invite some of our panel members back up to answer any questions.
Hi, this is more of a couple of comments. Number one, I love to hear how people are traveling all over the world, being on TPN and enteral feedings. The one thing to be aware of is if your health insurance is only Medicare and Medicaid, they only cover the borders of the United States. So if you travel abroad and you only have Medicare or Medicaid, if you have a medical emergency, you will not be able to get assistance from them at all. So that's something to keep in mind. And secondly, having written some articles for Oley over the years, the title of my section was always, "You don't know what you don't know." And I think what you guys are doing now is going to address a lot of that. And I encourage everyone here who is new, or even if you have had TPN or EN for a few years, you're still not going to know things. And I encourage you to meet people and get some friends here within this community. And so that when you leave here, you can call them and pick their brains about whatever might be happening to you personally. That the networking that's done here is essential.
Thank you. Thank you. We could probably do one more question.
Hey, so you're talking about a tool, but I feel like you guys were being a little bit vague. What is it? Is it like an app? Is it a website? Is it a worksheet? Like, what actually are you creating?
We were intentionally vague, so sorry. But what I can share is that it will be an online interactive tool where you'll be able to engage with various parts of the journey to connect you to different resources and tools that might be more applicable or useful in that stage of the journey, if you will. So for example, toolkits that are designed for, what to ask before you get a feeding tube, or what to ask before you get a CPAD, or, those types of toolkits that might be a little more helpful when we are working with a travel agency and planning our trip to the Grand Canyon, if you will, versus other tools, for example. So to be transparent, I was a prior nutrition support consumer, and my journey with Oley actually started when my insurance stopped covering my formula, and I was utilizing evangelizing or reaching out about resources, and I was connected to the Integral Donation Program. So, you know, pitfalls like that in the Grand Canyon, maybe we've run into a rattlesnake or extreme heat, or we ran out of snacks. I don't know. We'll have to think of what that's going to look like. It's going to be really cheesy and wonderful, but it's tools to help you to overcome different barriers. So.
Yeah, I think
Very
the
exciting.
formal
Yes.
outline is coming, but I think you'll see that as we're developing new resources, they're kind of those tools for those little pit stops on your journey. So,
Yes. A visual representation of some of the educational tools that we're building out on our website. So more to come.
We have to patent it, so that's why we haven't told you. Keep it under wraps.
All right, good. Well, thank you again to our speakers for sharing your heart and your honesty. And thank you all for being a part of this growing movement. And thank you for Zealand for sponsoring this session.